Hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode. Welcome back to the Feeding Pod. This is Bree, and today I am joined by Tova Fian, and she is a speech language pathologist and certified lactation counselor who is going to talk with us today about critical thinking skills, what that means, how to build them, a little bit of background, and then I'll throw it over to Tova to give us some background on her. But Tova and I met on Instagram, as I meet many people. That is one of the benefits of Instagram for sure. And we very frequently brought up the topic of being able to think critically as a clinician. How can we support students with this that are going through SLP programs? And I finally was like, let's do a podcast episode on this. I think more people need to hear us talking about this subject. So I'm really excited to get through and talk about this today. I think it's a really, really important topic and something that ultimately can help you as a clinician and or if you're a student listening for lifelong learning. I think it's really important to support you throughout your career. So Tova, if you will, kind of give us an idea, you took us through your progression of building your critical thinking skills as a clinician, your experiences, but give us an idea of where are you at now? What are you doing now as a speech language pathologist? Tell me more.
Okay. Isn't it weird to talk about yourself? So I'm a speech language pathologist, I'm a certified lactation counselor, and I left after many years at a children's hospital to start a private practice where I specialize in feeding challenges of all varieties, mostly infants and toddlers. Then I see a little bit of early language too. And those are really my passions. And I love so much just partnering with families and partnering with other providers to put together the pieces of the puzzle for each kid. And I teach dysphagia for Widener University, which is an awesome program. And they've been so open as far as critical thinking, adapting and growing and changing to meet the needs of the students. Should I talk about Get Cafe?
I was about to say, there's a little bit more. It's a little bit more to you.
Yeah, so there's a place called Get Cafe in Narberth, Pennsylvania. I should say where I'm in South Jersey, outside of Philadelphia. But there is a cafe that my husband and I were able to help start probably about 10 years ago with some amazing people. And it was a family that I met working in early intervention, actually. And their son has trisomy 21, and they wanted to start a business that would employ adults with disabilities. And so it's grown a lot. And now there's maybe between 40 and 50 adults that work there. And it's just an amazing place. You leave and your face hurts because you're just so happy. And I've learned a lot because most of my experience has been in pediatrics. So to see adults and challenges they face or fears or problems that their parents have, and also to see their victories, and the things they enjoy and the friends they make and all of that stuff. It definitely gives a broader perspective and informs me even working with them at a different age.
Wow. Yeah. I think that's, even just that experience alone probably did help in turn with some of your critical thinking, especially I'm thinking about
goals. And when we're writing goals, like even early
Oh
on,
my
we
God,
need
yeah.
to be thinking like long term, why does this matter? And so much of that is like, I mean, parents think about their child as an adolescent and as an adult so early on, and being able to like help them with that conversation and through it all. So that's very cool. If I'm ever in the, North Jersey, is that what you said? East,
So
North?
I'm in South Jersey outside of
Wow.
Philadelphia.
Okay.
Yeah. So that's where my office is, Pediatric Feeding Partners. And then the cafe is called Get Cafe, and that's in Narberth, Pennsylvania. Widener University is also in PA, in Chester.
Okay. Okay. Well, we have that Pennsylvania connection because I teach
Yeah.
at Pennsylvania Western University, and
Oh.
I also can harp on that school being very amazing in, talking about like they now have a course, which is one of the courses that I teach on information literacy and CSD, and being able to like talk through all of that and how that applies to our patients. So I love to see that. I love to see universities making that push toward it. So awesome.
Yeah, for sure. And what you said about goals resonates a lot too, because it really shifted how I think about even neurodiverse affirming practices and how much I had to learn. Just seeing the goals, quote unquote, that they needed is mostly like self-advocacy and finding people who had shared interests with them that they could be friends with or create relationships with was really what was valuable to a lot of the employees there who wanted to work on different things.
Yeah. And I think sometimes we forget that those are skills we can work on early on. Like even when we are working in that early intervention or birth to 3 or like, early school age, like we should be targeting that even then. So
Yeah.
very cool. Very cool.
Yeah.
Well, thank you. Real quick, if somebody wants to, I'm going to ask you this again at the end of the episode, but
Oh,
if somebody wants to contact you or find you, like, are there ways that people can, see your clinic and what you're doing?
yes. So my website is pediatricfeedingpartners.com. And then I'm on Instagram at Pediatric Feeding Partners. Those are probably the easiest ways to reach me.
Perfect. Yeah, that sounds great. And I'll make sure to put that in the description for anybody that's looking for it. So if you have extra questions or if you're in the area and need some services, then you can reach out to Tova. You talking about how like your flow from, like going to early intervention to the hospital to then like teaching made me think about how, like in a lot of med schools, they talk about like this application of like see one, do one, teach one. And it like kind of makes me think about that. And like, I feel that when I'm teaching students of like, I have to know it to a whole other level.
Oh my God. Yeah.
Which is where I'm not saying like, oh, you have to be teaching courses in a university to get to that level. But like, I highly encourage people to like supervise and mentor and like provide that, because when you do that, first of all, you're going to learn new things because your student's going to be like, well, what about this? And like, I hope to learn things from my students, but also like you have to really know what you're doing to be able to provide that information to somebody else. And I think it's not just like, hey, do this because this is how I do it, but also being able to provide the rationale behind it, being able to provide the evidence behind it. Like it just forces you to really read into that piece.
Yeah.
So that's just like immediately what came to my head when you were saying that. Cause I was like, that's kind of what you did. You went from like seeing it
That's
with
so
like
true. That's so insightful. Yeah.
mentoring to doing it at the hospital. And then now you're teaching it.
Yeah. And I think with every new phase for me, there's been so much discomfort because I want to be good at stuff. I want to be I'm a perfectionist. I'm really hard on myself. And so when it's new, it takes time and it takes a lot of effort. And I think that applies to critical thinking too, where like on the front end, it can seem really overwhelming, all the pieces of the puzzle with pediatric feeding and swallowing that we have to kind of like put together and then figure out what we're going to do. And I think in the beginning, it's overwhelming and it could be tempting to just do like a cookie cutter kind of program or
regurgitate. Here's the information
everybody else is doing in front of you. Yeah. And so like on the front end, that might be super tempting, but just in reflecting, I've been reflecting like leading up to talking to you and thinking that, yeah, it's more work on the front end, but then now I would love to do some kind of measurement of how many treatment sessions I need with a family, because I think it would be a lot less than, first of all, than when I started. but also I'm kind of losing my train of thought, but does that make sense?
No, it does make sense. Like almost like a comparison to like when you first started as a clinician, but also thinking like, oh my gosh, my brain's going in like 5 different directions now.
I know, me too. And I'm I'm sorry.
Yes, between the two of us, it's fine.
Yeah.
So what I'm thinking though is like, okay, if I saw the same family when I first started in my CF versus if I saw the exact same thing right now, how much more efficient would I be?
That's what I'm trying to say. Thank you.
Of fine tuning my critical thinking skills.
Yeah.
Yes, absolutely.
Like, okay, so for myself, there's that efficiency where in the beginning I would see a family and I'd be like, are you okay if I record some of this and like share it with my mentor? I'd be open about it, and I would have to leave and I would have to take notes and look things up and talk to. Yes. So that efficiency for me is there, but also thinking about if I were to use that manual, that like cookie cutter manual, on day 1, you do this, and on day 2, you do this, and blah, 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 that might make you feel comfortable in the beginning, but again, so inefficient. And then like you and I talked before about how it doesn't matter how many quote unquote years of experience you have, like what is the quality of that experience? Are you doing the same thing, using your same, workbook for everything?
Yes.
Are you like, constantly learning and growing and
That's what, the first time I heard that was from Dr. Ianessa Humbert, where she said like, okay, you have 20 years of experience. Do you actually have 20 years of experience, or do you have 20 years of the same experience? So you have 1 year of experience 20 times, or do you have 20 different experiences? And like, that's what you're seeking for. Because if you have someone that's just done the same thing over and over and over again for 10 years, that's cool. But I would rather go for the person who has 5 years of evolving and changing and, challenging their beliefs and practices than that person who's like, no, this is just how I always do it for 10 years. So, yeah.
And I think to do that, it takes, to be a good critical thinker, you have to be open that things are evolving and that you might look back. Like I look back on some things I did in therapy and I feel so cringy, and I wish I could call families and apologize, but I know that would be inappropriate.
Yes. Oh, I've had that thought too, where I'm like, what if I just like talk to them? And meanwhile, they've not thought about me ever. Like,
no,
but I still think about them all the time.
Yeah, no, I do feel bad about those things. And it's also like you mentioned Dr. Humbert, and she has taught me so much about thinking outside the box and like, why are you doing that? Why? What do you see that? Actually, and does it matter? Yeah. Does it matter really? Yeah, no, it's her courses are for the adult population, but thinking about how that applies to pediatrics and how we think about it is, oh my gosh.
Well, her podcast, I'm going to tell you to go leave my podcast, go to her podcast. Her podcast is Down the Hatch, if I didn't say that clear enough. It is also great. And I think that, for a pediatric therapist, so much is relevant to.
Oh my gosh, it's fire. Even how she talks about, like, I know we were going to talk about this later, so we can talk about it later, but thinking about like, what are the things that we're sort of just on autopilot doing, and taking her course really helped me with that. Because I think, when you're in a busy setting, whether it's like a hospital or whatever setting you're in, I'm just saying hospital because that's what I know the best, but you'll have these clickable templates to go through an evaluation or to go through a treatment session. And it can become autopilot. And it's like, am I actually getting a picture of this child and the nature of how they're functioning and what we need to work on? And did I actually even see that? Like if I'm doing a clinical swallow evaluation for a child, there's a clickable box in there. Like, did they have a delayed swallow initiation? And people are clicking that box, and I'm not blaming them, but it's like, because I did that, but we have to pause.
It's there. I feel like I should click it.
I feel like I should click it. Yeah, don't click it. You didn't see them swallow. You have no idea if their swallow initiation was delayed. You can comment if you notice things, like if they were gulpy, or if you notice increased work of breathing or nasal flaring or something like that. But like, don't comment on things that you can't see. That was it. And I didn't even realize I was doing that. So being open that things that I'm doing could be better. It's definitely helpful with critical thinking.
Yeah. I think too, like, I mean, we can just like go ahead with that topic of like critical thinking
Yeah.
versus like going with what the practice is. Like well, everybody else is clicking the box. They click that
Yes.
box on every swallow study they do. So I guess we all click the box on that swallow study. And it's like, well, no. And I think so much of critical thinking is just slowing down. Like if you can just slow your thinking by like a tenth of what you're currently thinking at, usually that's like, it's like, that's enough for you to be like, wait, why did I click that? Literally just that question,
Yeah.
right?
Yeah.
To just tell yourself like, okay, if I can slow down enough to tell myself why, or why does it matter? I think that's also one, not just like, why did I put that, but like, does it even matter? So, or does it make a difference for this individual patient? And I think that goes into some research stuff as well, right? So if we're seeing a study, for example, I find this a lot in tube weaning research. So I'm just like throwing this out there. Okay. I feel like this is not directly related, but kind of related. Okay.
Yeah, let's go.
I do this a lot with tube weaning, where they talk about doing like very intensive tube wean programs versus more child-led tube wean programs. Okay. And sometimes what they'll find is like, it may take like one day less to get fully off the tube feed, okay, by doing like a more very, very intensive versus like, let's just remove a little bit, let's like decrease at a slower rate, okay? So let's say there's 1 day difference. Statistically, that is significant, but clinically, is that significant?
No.
And that's the part where I'm like, okay, but like, you like took this child's feeds away super, super quick. That was probably really hard on their body and mental load. And so like
The family too. It's like,
yes, and the family being like, oh my gosh, oh my gosh, oh my gosh. And in an intensive program, you're probably following up at that hospital 3 times a day. You're going in, you're doing all this stuff versus more of that child-led where like it's a little bit slower and maybe you're checking in once a day, but like a phone call or a video, and like think about this. Now, some child-led weans can take a lot longer, but I'm kind of thinking about this like sort of a mix of child-led and physician-led where you're like, let's reduce 10% every day. So a small amount versus like cut 50% day 1, cut 75% day 2. And so I bring that up though, because that's one in the literature that I see a lot where it's like, okay, statistically that's significant, but the critical thinking piece tells you, but is it clinically significant? And so like, that's the part that like we have to reflect on, which is where I love like implementation research. And I think more and more researchers are moving towards saying, hey, this is what we found, and this is how it can apply clinically, which is where having clinicians involved in research is also very important because they can provide that reflection. But even for you as the person consuming that information, it's like, cool, that was statistically significant, but how does that matter to me in the caseload that I'm actually seeing?
Right. Yeah.
So that kind of made me think of it though, of like that, like the critical thinking versus like going with the like flow kind of thing of like, oh, well, like the research said this. And it's like, I mean, everyone who knows me knows that I'm a proponent for like, what does the research say? But like, it only matters to a certain degree.
Yeah. Well, and context. And even you mentioned MBS IMP. So in my dysphagia course, the students take the MBS IMP course because I think it's really cool. They get so much exposure to so many swallow studies and so many different types of like a range of anatomies and, just so much practice with that. But it trains you to be very black and white and score and what is it, but it's not going to give you that critical thinking, that application piece, which is beyond important because, okay, you can check those boxes and you can identify them, but now what? You have a person in front of you who wants you to tell them what they should do when they leave, or like, you have physicians waiting on you to tell
like,
you.
well, according to these things, and they're like, so what does that mean?
Add it too
like,
on their tongue-based retract. Yeah, like, okay. Yeah. So that critical thinking piece, that is hard. And I think it's hard too, if we're thinking about students where they're coming from an undergrad background where everything is black and white and multiple choice and true and false. And then even in graduate school, a lot of it, I think it's really hard. When I looked at the definition of critical thinking, it was like, I forget, it was the Oxford Dictionary definition, but
I'll pull it
up because it said something about like how professors have a hard time with this.
Yes. So it says critical thinking, noun, the objective analysis and evaluation of an issue in order to form a judgment. And the sentence is, professors often find it difficult to encourage critical thinking amongst their students. The fact that that's their sentence is so
I know.
fun.
I know.
It is. Well, and I think that, so it's funny because they say encourage critical thinking, because I don't know that critical thinking, here's like I guess like a, what's the word I'm looking for? Unpopular opinion. I don't know if it's an unpopular opinion, but a hot take. I don't think you can directly teach critical thinking. I think you can facilitate and encourage, but I don't think you can directly teach it.
Yeah.
I think you model it and
Yeah.
you like encourage and facilitate opportunities to learn it, but I truly think it involves like internal reflection and internal learning to where you can like teach it directly.
Yeah, I know. I think that's a lot of therapy too, right? Like you're not going to make it eat. You're not going to make a family follow through on recommendations. You're meeting people where they're at and then tapping into that internal motivation. And and that's something that is actually really freeing, because I would take it so hard if students weren't, picking that up, or if I have a family or a child where things are stalling and it's like, I have to know where my responsibility ends and I'm not in charge of like quote unquote fixing people or making people do anything. I'm going to offer what I can offer. And then,
we facilitate and encourage. That's the role. I want to go back a little bit to the critical thinking versus kind of just like, checkbox thing. And I want you to talk a little bit about, because I don't do swallow studies. So I want to hear your take on instrumental like rules and how that like doesn't necessarily apply to real life, and like how to kind of think through that process, because I know as like the therapist who gets a child, I get the results from the swallow study, but then I'm like, okay, but like how was it set up? What did you do? How were they feel like? And so I would love to hear more about that part.
Oh my gosh, there are so many things. Okay, so let me talk about swallow studies. Are amazing, and they give you obviously insight that you would never have if you weren't able to utilize that technology. Amazing. And it can really inform your treatment plan. But there are also other things to consider, like usually in a swallow study, a baby or a child is positioned absolutely perfectly. Oftentimes in seating equipment, like that they do not have access to in their home, like a tumble form, or the opposite. Sometimes we'll have a wheelchair and it doesn't fit in the space to do the study. And so the child is in a chair that's unfamiliar and maybe not in as optimal of a position as they're used to. And then if we think about trauma, and we think about children who many times have been through many procedures and studies and things that feel invasive or uncomfortable, and we're asking them to sort of like perform, and it's a performance. It's not, we try to make them as comfortable as possible and play songs that they like, or, show them videos that make them comfortable, have them hold a lovey, whatever. But at the end of the day, it's not the same as being at home with their family and trying to use. But I will say, like, so when it's like, oh, we do it this way, and like you start with this viscosity and you work your way up and you only use the brand and blah, 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 and getting pushback in the beginning for mixing it with a child's actual drink or their actual food, because it was like, but I want to see what they're actually doing. And also it's way more motivating because it's what they're used to. And so that's something where I feel like more and more people are starting to do that, but it takes someone being like, why are we doing this? How is this helpful? Yeah. And even I had a message yesterday from a mom who got a repeat swallow study done. I didn't do the study. And she said that this child has been through so many surgeries, so many studies, so many fees. And she had to do one for an upcoming surgery, and she was crying, she was gagging, and they had mom's syringe boluses into her mouth. And she didn't aspirate, which is shocking. But if she did, I'd be like, well, yeah, if someone was like,
that's not applicable to when she's calmly sitting at a table.
Right. And then they actually recommended at the end of the study that they repeat it again after. And this is a child who is doing so well with just like a few visits of therapy. And it's just, so there's a lot there's a lot of different people's normals too, like in different parts of the country or different
Yeah.
institutions.
Well, and even like places where the therapists that are doing the swallow studies are primarily adult-based therapists, but they are also just, hey, even though you don't do pediatric therapy, like just because of limited numbers in hospitals, it's like you still have to do pediatric swallow studies. So like
Right.
they do that, and it's just not the same when we're looking at like applicability and like tolerance
Right.
of them. Like
Yeah.
it's kids
And
don't like them.
no, and they really don't. And the other thing is if I call myself out and think about a study that I did when I was first starting to do swallow studies, and it's like you get so conditioned to look for the impairment and to look for what's like not normal. And that was before I understood that there is such a variation in normal.
Yeah.
And I think we're still really trying to figure that out with pediatrics. And when we think about aspiration and how much is too much, and what does
Normal.
it really need? Yeah. But I remember one family in particular where if I think about bias, I was seeing what this baby was doing when they were feeding. I had a picture of what it was going to look like on the study. And so I was looking for anything that didn't look typical, anything that was going wrong. And I remember pointing out this like minor delay in swallow initiation, but the airway protection was there. It was functional. And I really harped on it. And I think, I mean, it's one of those things, right? Where like, they're probably
Well,
not
that's
thinking
sort of like an example of confirmation bias.
confirmation bias. Yes.
You had an idea of what you wanted to see, and so you were looking for that validation that you were
Yeah.
already like
Yeah.
confirming the belief you just already had of like what's going to happen on this picture.
Right. And then the other problem with that is that I look back and I feel really bad because I perpetuated fear for those parents with their baby and maybe gave them more restriction than what was actually needed because of my fear and because of me just like not having the knowledge yet of that variation of normal and being able to synthesize all the information, all the pieces of the puzzle. So
Yeah.
Yeah.
Well, I think, I'm going to kind of like lead us to this next topic we wanted to talk about because you mentioned fear, which
Yeah.
is fear-based decision making.
Yes.
Versus
Oh,
actually
look at that little segue. I like that.
it worked out really well. So actually like thinking about like why and how and like examples of like this fear-based decision making, because I think this is something that comes up a lot. And I know like I used to be the same way of like, can I offer something by mouth if they've aspirated every consistency, if they're found to be a silent aspirating every consistency, like what do? I don't think I can give them anything by mouth. So like, should I just give them like a non-nutritive thing to just, see what happens? And so, yeah, I would love to hear some examples of like how this plays, how you've seen this in clinical practice, in your practice. I'll talk about how I've seen it in my own practice, but also just like across the board, how we can fight a little bit of fear-based thinking and make sure we're thinking critically and not being led by fear, because that sometimes can happen. So yeah, if you could just shed some light on that and start talking about some examples there.
So I was thinking about this a lot since we talked last week, and I was actually thinking about something that you said. I can't remember how you worded it. Like you can't teach critical thinking.
Yes, I feel like you cannot directly teach it, but you can facilitate and encourage critical thinking.
Yeah. And I just wanted to make sure that it's clear that you can learn to be a critical thinker.
Yes. It's something you learn. Absolutely.
Yeah. But it's like, nobody can make you learn it.
Yes, exactly. It's not like I can be like, read this thing and now you're a critical thinker. Like active. Both parties have to be active in learning it. Yeah. Glad you clarified. But again, I told you like that was kind of like my hot take. It's not like that's not like proven. You know what I mean? Like I don't have any science behind that piece. I just feel like through even my own experiences of refining critical thinking is where it's like, whoa, this isn't something I could just read about and be like, oh, okay, cool. I know how to do this.
Yeah.
You have to actively engage in it ongoing. So yeah, continue.
So I have so many examples of fear-based versus critical thinking. And a lot of times the more I thought about it, I feel like fear-based thinking just comes from not having other ways to think about it. And so when I'm feeling afraid about a patient, even now, it might be because like I have questions about what I'm doing. And so instead of just acting out of fear, I need to be able to ask someone for help and look for resources and figure out what I'm going to do so that I'm not operating out of that fear that I have, but I'm operating out of like what's best for the patient. And I think it also comes from when we put too much pressure on ourselves that we're the ones who have to like fix, like we have to fix it. We have to fix our problem and do therapy. And that's not helpful to do things to people. So we talked about oral stim a little bit, and there's definitely a place for oral motor and figuring out what we do with our mouth when we're eating and progressing functional skills and therapeutic touch. And there's so much there that can be really beneficial. And so I think what we're talking about with fear-based thinking is more like getting stuck somewhere where you're doing the same thing week after week, and you're doing these things where you touch their face and you rub different parts of them, or you progressively move and you have them like kissing food, but you're kind of like, you're not moving forward. That's where we can start to feel fear, because it's like, really, what are we doing? Like we shouldn't, if we're stuck, it might not be. And I find a lot of times clinicians are quick to say like, well, they're not ready for feeding therapy, or like they're plateauing, instead of looking inside and being like, well, where can I find more help for this? Like, what's something that I'm doing that might be preventing them from moving forward? Is there another aspect to feeding that is tricky for them? Are they stressed out? Because you definitely can't learn when you're stressed out. So just starting to look at the different pieces of the puzzle, if you're stuck or if the person that you're working with is stuck.
Yeah, I absolutely agree with that. I feel like that resonates so much with how I think about fear-based thinking as well, is that a lot of times, like I use the phrase a lot, like I fight fear with knowledge. And I
Yeah.
truly think that like so many times when I'm afraid, and that's like not even just therapy related, anything related,
Yeah.
like a family member receives a certain diagnosis and I don't know what that is. I don't know what that means. Like I will fight my fears about it by learning more about it. And
Yeah.
so, yeah, it's like, okay, well, I could stay and just say, oh, I'm just going to be scared. I'm not going to read about it. I'm not going to learn about it. I'm just going to stay here. But there's other things we can do to learn about what's going on so that we don't get stuck. And, you know, thinking about that oral motor example, it's like, yes, there's a place for so many different strategies, and what works for one patient might not work for another, but we need to make sure that when something's plateauing, we're assessing that internal evidence of, okay, maybe what do I need to change? Is it the reason I'm not seeing progress or a different response from the child, not because of them, but because of what I'm providing, the antecedent, you know, the intervention being offered.
Yeah. And it's so true that I think there's also a healthy fear and a fear that drives us to keep learning. So it's just about getting stuck. So if I think for myself, like when I first took this job to teach dysphagia, I was so scared. I was so overwhelmed. I was doing all the research and the continuing ed and reaching out to people, and because I wanted to make sure that I did justice by this topic and I was preparing graduate students. And so it was like a good kind of fear that drove me to more knowledge, like you're talking about. Or even when you asked me to do this podcast, like I almost know now that if I feel uncomfortable, like if it makes me like clench my whole body and like want to poop a little bit, that I probably need to push myself to do it, because it's going to be a really good like learning opportunity, growing opportunity. And I even feel like my brain, I'm learning so much just from preparing and from talking to you. So I think those kinds of things can be really healthy. And I also think it would be bad if people had no fear, because it's not about like fear or no fear. It's like acting out of like doing things out of best evidence. So it's not like, I have no fear, I'm just going to give this child thin liquid and see what happens. Like that's not good either. It has to be an informed approach.
Yeah, I agree. It's almost like, you know, thinking like critical thinking versus fear-based thinking, but like fear-based learning. Like, you know,
Yeah.
it's okay for like your learning to be driven a little bit by fear, and recognize like, I'm just not sure. Cause like uncertainty is going to happen, right? I feel like the more that I know, the more I realize I don't know anything. Like I'm like constantly like, Bree, you don't really know anything about anything. And so, you know, also recognizing like, those pieces, I think, like you said, is important. We don't want to have no fear, but we want to recognize how we respond to that fear and how we move forward with it. Yeah, for sure. Okay. Do we want to provide any other specific examples or
So we talked about STEM. What were some of the other ones?
so one thing I'm thinking about is specifically related to like the NPO patient.
Yes.
And then what do you do? Like being afraid to try any type of oral trials? Because I think there's a difference between, just chilling and watching the child where they're at and actually like therapeutic oral trials, And so I would love to hear your take on that too, about like, the child who has been NPO, they haven't had anything by mouth, and like, what do you do? How do you approach that when you have this swallow study that says, frank aspiration, all consistencies? Where do you go from there?
Yeah. So if I had a referral for a swallow study for a child who's been NPO, yeah, so I would have a problem with that because it's like taking casts off of your legs and then be like, okay, now run. But you haven't done anything to help. And depending on how long they've been NPO, there might be deconditioning. They also, like, if they've always been NPO, they've actually never had any experience. So it's just not giving us an accurate picture of what they can do. And depending on why they were NPO, we really a lot of times would want to start with having some oral trials in therapy and building till they're taking enough so that we're actually going to get good information from a swallow study. Because if we go into the room and the baby or that child doesn't want to take anything, or they can't take more than a tiny bit, then we've kind of wasted that visit, radiation, money, because we're not able to really get an accurate assessment of what their swallow looks like. So I think that's another time where there can be fear, like, oh my God, but what if they aspirate? But really knowing that aspiration is also extremely complex, and it doesn't always mean aspiration pneumonia, and knowing the threshold and thinking about for that specific patient and how much can you try in therapy before, so that it can be useful.
Yeah, exactly. I think that the fear-based thinking of like, I've had people ask questions about this or talk about this, or I've heard other clinicians, who do the swallow studies say the same thing, where they're like, if this child hasn't taken anything by mouth, like this is not going to be an accurate picture of what's going on. You need to be working on something. Or the opposite. Maybe there's a child who has been taking things by mouth. There's not really anything super overt going on, but because they're medically complex or, have immunocompromised status, the clinician, I've heard parents say like the clinician just like will not start feeding therapy without a swallow study as a baseline. And it's like, it's not necessarily how we should be approaching things. And we need to say like, okay, like what is going on with the child? Or, well, they haven't had they're 5 years old now and they haven't had a swallow study since they were 10 months old. Like, let's just update it. It's like, but why?
Yeah, they're doing it annually, but like no therapy has changed and nothing has changed with their eating habits. So why are we radiating them and having them go through this uncomfortable test to,
Yeah.
And I've seen lots of other examples too, where there are referrals made for swallow study based on a diagnosis, like of a certain genetic syndrome where maybe aspiration could be a piece of it, or advancing PO, not based on the child and what the child looks like, but based on just some like weird prescriptive number, like, okay, we're only going to do this many mLs because they have this diagnosis, and then we're going to increase them. I've seen children get G tubes who didn't need them because they just never tried. Like they just never got to try. So there's a lot of gravity to what we're talking about. Like I'm smiling, but it's pretty heavy what we're talking about, because people are trusting you with their most prized possessions and like putting their airways in your hands. So it is. This is really important, heavy stuff.
Absolutely. I think it just, kind of goes into the difference of, making sure that we're not just going to somebody's house and recommending strategies that aren't actually therapeutic in nature. And I think recognizing sometimes like maybe, and sometimes there are moments, right, where the child may need to reach more medical stability. Maybe they do need to have medication management right now, or they need something else to go on. And that's okay. And I think also recognizing those times where like sometimes it's not always appropriate at this moment, and that's also okay. But we want to make sure that we're not assuming a child is not capable of something because of our fear. Like just making sure we're not a barrier to them. We're facilitating.
Yeah, you talk about like presuming competence
Mm-hmm.
and just giving children a chance to
Yeah,
show us what they can do and what they want to do, I think is really important.
mm-hmm. For sure. Okay.
So I think a huge part of critical thinking is having a really solid understanding of normal development. If you have a really solid understanding of normal development, it really helps you see when things are not going the way that you would
The like range of normal.
and the range of normal.
Yeah.
And also it helps you pick up on when things are getting over pathologized or over diagnosed. So I have examples of this that I feel very strongly about.
Yes. Share them.
So I just made a reel today about drooling and normal drooling. Okay, your face right now. So drooling.
I'm making that face because I saw a post earlier today someone sent me about how drool is never normal.
I literally saw the same one, and that's what made me want to make this reel. Okay. Drooling is normal for babies.
Yes.
Oh my God. Normal when they're learning a new motor skill, normal when they're teething, normal when they're putting literally every single thing they can find in their mouth. Normal. Is there a time when there's excessive drooling? Do we see children with neurodevelopmental disabilities who drool excessively, who might need medical intervention or other things or allergies? Yes. But to say that anything is always, I mean, I can't. The fear that causes in parents when you over pathologize something that is normal for many babies.
Yeah, that's one of my biggest pet peeves when someone's like, just because it's common doesn't mean it's normal. I'm like, that's literally how we define normal. By it happens most commonly. Like, that would be like, it's not normal to have 2 arms, even though most people do. And that's the most common. It's like, if you reverse that logic or use that logic in any other situation, it doesn't make any sense. Like, it just doesn't.
Another one for me is gagging.
Yeah.
Gagging is a biological reflex that babies are born with to protect their airway. So we should never, ever, ever, I will say never, because it's a never, be trying to desensitize a gag reflex from a little bitty baby. That is something that matures with time and experience and helps them stay safe.
Yes, I absolutely agree. The getting your hands and fingers in an infant's mouth from birth to desensitize is not what we're supposed to be doing.
Right.
They need that gag.
And if you have a really firm understanding of normal development, you know that gag reflex is going to start out really forward in the mouth and it's going to mature and move back 7 to 9 months old. It's going to be in the back third of the tongue. So these babies, they need to grow in time and experience. And sometimes they do need help for sure. It's not black and white, but to say oh, we have to
But understanding that normal piece, right? So okay, typically what we would expect is this. Yes, there's exceptions to that. And that's when children need a little bit more support. My big one with this is that reflux is never normal.
I've never heard that one.
Oh, yeah. Reflux. That's the big one. Reflux is common, but it's never normal. It's literally anatomically, it's normal in an infant. And it makes my eye twitch. If you were watching the video right now, you'd see it's twitching. That's the big one. There's so much fear. That's a whole, there's a lot of fear mongering about reflux and how parents are supposed to respond. If you're listening, I wish you could see Tova's face, because
if you know normal development, you know that gastroesophageal reflux is a part of normal baby life. And it's a part of their digestive system maturing and them gaining postural stability and all of these things. And it becomes a disease process when the baby is uncomfortable or disturbed by it.
Yep, not
But
gaining
all of us, and guess
weight
what? All
or-
of us have reflux. All of us have times that things come back up, but we don't all have gastroesophageal reflux disease. But
Right.
gastroesophageal reflux is normal for babies.
Totally normal. Totally normal. Yeah, that's my big one that I get. Because then
Oh.
there's people over servicing for things that they claim causes reflux, when in reality, it's just a normal part of growing and developing as an infant. And that's one where I see the placebo effect very heavy, because it's placebo effect, where they have a certain intervention. Let's say they get their tongue tie released because that causes reflux. I'm using cause in quotations because we don't actually have evidence of that. But they claim, oh, they need their tongue tie released because that's why they have reflux. They have their tongue tie released. They do some oral motor something. The reflux gets better over time. But really, the reflux got better over time strictly because of maturation. And so they attribute it to this thing, when in reality, normal development tells us it's going to get better over time, because that's just how it happens. So, yeah.
Mhm.
Ugh. Okay, I'm glad you brought that up, because it's so true. So true. I feel like there's
Tough for your firstborn children, Brie. Talk about tongue ties. You better watch out.
I know, right? They're all gonna have it. They're all gonna have one. But the thing is, like, and that's why
No,
always
I
talk
mean,
about,
like, people are gonna come for you. Actually, my daughter did have a tongue tie that was like a classic heart-shaped tongue tie that she did have released. And there
well,
are
and-
definitely times where
yeah.
it's impacting function and it does need to be released for sure.
Mhm.
But I think it's about coming at it with an understanding that it is definitely one piece to a very large and complex feeding puzzle. And I think in general, for me, thinking about this with like critical thinking red flags, like if there's like a pill, if there's like, this is your solution, this is your thing that's gonna fix all your problems, and it could be anything. Who did I hear talk about this? I think it was the women from Unbiased Sci Pod. They did a podcast with Dr. Mike, and they were talking about how if there was a pill for baldness and being fat and being ugly, like we would all be like skinny and beautiful and have really thick, lustrous hair. And so when there are these claims, like this solutionism that happens, that like, yes, we'll fix this with blah, blah, blah. My like red flags go off. Like, yeah, that's a
For sure. And I agree. Like, it is a real diagnosis that can impact function. The biggest thing is when there's like the quick fix claims, or claims that it impacts certain things that we just don't show it as being related to, right? And I think the other thing is like for tongue tie, for me, it's like the percentage of infants that we see in literature that have a tongue tie compared to the excessive amount being diagnosed with it, is where there's just like a mismatch of that. It's like, there may be other things that are going on, or other interventions that are more appropriate to start out than going to a more invasive type of intervention. That's kind of my spiel with it. Like, I've made referrals for tongue tie releases, but not after trying something less invasive first.
Yes, fear-based thinking. And this is coming from somebody who takes medication for anxiety. So
Same.
I'm gonna have like a low level of fear no matter what. But
yeah, my baseline is
like a little bit scared. Yeah. But in some ways I think that's good, because it keeps me honest, and it keeps me like thinking critically, because I'm like, wait, is this the right thing?
It makes me ask why. Because if I
Yes.
can't justify the why, then I'm going to stay in fear. And being able to justify the why, I think helps alleviate that for sure.
For sure. I think, okay, so wait, I just want to say one thing and then go back to what we were just saying, because I don't want to forget it. So you talked before we started recording about taking a course or doing something, reading something where you don't where you come at it with maybe a bias of like, oh, I don't know about this. And I think that is an important part of critical thinking. And that fear-based thinking is like, if I'm afraid of something or I'm judging something, I have to like make sure I'm understanding it first.
Yeah.
because I might not understand why somebody's doing something or recommending something, or I might just not be familiar with that approach. So my guards go up, but I have to be like, okay, let me just really see what this is about. And there might be positives in it, or maybe like you said, if I'm asking why, at least I can feel confident with that it's not my value, or it's not an approach that I want to use. So I wanted to say that while I was thinking of it, because it is important to me. And I think it's an important part of critical thinking, because we can get in our like camps and it can be very polarizing, and people get closed off to anything that's different or that challenges that bias. And oh my gosh, I should grab it. I have this book that I found at a yard sale from the 1950s it was what they would give to parents when they would go home from the hospital. It was an infant care book. It's so freaking cool. And it talks in there about how you should lay your newborn out in the sun for 15 minutes a day. And you should give them, you're like shaking your head like, oh God, give them cod liver oil, orange juice every day. And that's what science and medicine told us then, that was the best thing for them to get vitamin D, and the best thing for digestion, and then you learn better and you do better, but you have to be open to how science evolves and how we apply it.
Well, so, and I think too, because I want to say this before I forget, is something I hear a lot from people is that, rely more heavily on their clinical experience or anecdotes and testimonials than they do the literature. Is like, well, science hasn't caught up yet. And in fact, what we see is that clinic hasn't caught up to science. Now, science takes a while. Don't get us wrong, right? Like there's years that go into a study and all of that. But what we see consistently is it takes on average 17 years for research to reach clinical practice as a whole. So like it's slowly reaching people and going down from there. And so I get like, that's like a pet peeve of mine where people are like, well, science hasn't caught up yet. I'm like, we haven't even caught up to science yet. So like, you can't even say science hasn't caught up yet, because we haven't even caught up to what the science has been saying. And so I think that's like but that's kind of a logical fallacy, right? Of like, it's not a rational argument for why you're doing something if we have science that says otherwise, because a lot of times there is science to help guide it. It's just a matter of like becoming aware of it too.
Yeah. There's an OT, I think she might have retired this year, but she's so amazing and she mentored me a lot. And she's she's accomplished so much. She's incredible. And I would ask her, so what courses do you recommend? And she would say, you know what, Tova, I set aside 2 hours a week and I see what research is coming out. And I look at all different disciplines of research. And she said, if I'm going to take a course, I want to see the references before I sign up. I want to see, what I'm going to be learning and where it's coming from. And I thought that was such valuable advice. And it is easy to want like a quick fix or hot new.
I love that though, because I get that question all the time. Like, what CEU should I take? And, I have a couple, but I was like, this was a good course. I liked this. And so if you like have a specific, I want to learn about this, I might have an idea of one I would recommend. But routinely, I tell people like, I think you can learn a lot of it by just reading the research. Like if you just spend the time accessing that. Now that's harder because you have to take that the step further, right? You have to understand, okay, it's statistically significant, but is it clinically significant? How can I modify this to apply it to my patient? Like, it's hard work, but it
kind of reminds me though of like, I don't know if this is going to make sense, and I haven't seen this show in forever. I don't even know if it's still on, but like Who Wants to Be a Millionaire?
Yeah, I think it is still on.
Okay.
I don't know who like hosts it or anything now, but I think that's
okay. Because how there's like 3, I don't even know what the 3 options are. I just know one of them is like phone a friend, or you can get a fact, or, there's 3, whatever.
Yeah.
So even when you're talking about that, like if you're somebody who has a hard time understanding the research or knowing how to apply it, if you have that phone a friend, like if you have a support piece where I know for me, if I have a question about a cardiac baby, like I have my person that I'm going to call, and you start to, if you're having a hard time, you have that in place.
Yeah, that is true. And I think that's where like having like journal clubs at your place of employment can make such a difference. Even if you just start out with like 1 article a month, like even if you start with something small. So when I used to work for an outpatient clinic, we had weekly. So like one time a week over lunch, we would go through and we each took turns like picking the article that we wanted to review so that everyone could pick something like a little more relevant to them. And then we would all come together and be like, how did you interpret this? How did I interpret this? What patient would you maybe use this with? And like getting some of that critical thinking with it makes such a difference for sure.
Yes, for sure. Because it is a muscle that you strengthen, I think, over time.
I do too, because I think just as we like learn those things like in clinic, the more articles you read, the easier it gets to appraise it and understand it and make it applicable.
Which is what was frustrating for me in the beginning because I was comparing myself to my mentors who had been speech pathologists for, 15 years, 20 years, like so amazing and so knowledgeable and just so much experience. And I wanted to be there. Like, I want to be there now. I
just want to be there right now. I want to be able to do all of that. Yeah. It takes a lot of practice.
Yeah. But like, that's not hot, right? Like people want like solutions. We want to know like the pill I have to take. I
don't want to have to work now. I just want to like know the research and know for sure. Okay, let's go back to fear-based thinking. Let's talk about some examples. No, we're good. Let's go back to some examples of this and like kind of what we're talking about when we say critical thinking versus fear-based thinking.
Yeah. So, fear-based thinking could look like a patient that comes in for their evaluation with me, or maybe I'm covering a patient and find out that they've been doing oral stimulation for 3 months and weekly in therapy. And
I want to clarify to people that are listening, especially if like someone's a newer clinician, like when we're talking about oral stimulation, we're talking about things like ensomes or like passive
touching their cheeks.
Massage. Yes. Like touch cheek, stroke cheek, no food involved, no like it is just like kind of a massage
touching your lips.
And sometimes it's not even like rotation, like sometimes it's like touch and hold. I'm literally like, for those of you listening, not looking, I'm just touching on my face, like that's kind of what I'm just doing.
And I will add that I'm certified in infant massage, and I only say that because I want to make it clear that there are many benefits to appropriate massage and tactile cues and things like that, 1,000,000%. But if we're thinking about therapy and we're thinking about a family's time weekly and we're thinking about charging insurance, if you're doing that for 3 months, I would just wonder, is that something that the family could just do at home and look for signs that they're ready for more? Or also like, why aren't we trying anything at all by mouth? Is there a reason? Did they have a study that went wrong? Were they showing signs and symptoms of aspiration? And that's often what I'll ask families, well, why? Do you know why you're doing this? And I think that's huge too, is like, we should be empowering these families for their why. We should be helping them critically think because they know their kid the best. So if we teach them why we're doing things and we're the experts in feeding and swallowing and we can empower them, then they're coming at me with like, well, I noticed this week and he's really motivated by this. And then fire happens. Like it just off because they're the expert on their child. So we're putting together our expertise and just works much better that way.
Yeah, for sure. Okay, continue. I just wanted to make sure like we understood what we were talking about with oral stim. So
I'm glad you did that. So that would be one example. And I think in general, like I mentioned 3 months as like an arbitrary number, but I think in general, we should see forward momentum.
Yes.
And if things are plateauing, I think it's easy for therapists to maybe blame the family or
not doing it enough or not doing it right.
Or they're not ready. And I think we have to make sure we're looking inside. Like maybe I'm not the right fit for this family, or maybe they need a different approach, or maybe I need to learn to try something different. Because if we're doing the same exact thing every week, I mean, that's the definition of insanity. We're going to get the same result. And I'll ask family, like, how is that working?
Even though it's not working.
How is it working for you? It's not okay. Try something different. And it's scary. And I think if we're talking about confirmation bias too, with this fear-based thinking, there's fear for these families too. Like, this is the narrative I've been fed for this long, and you're telling me something different. Like, that's scary that we're pivoting here. Like, that's hard. And so,
For sure. And I think like going into this is like a side note, but thinking about approaches like the oral stimulation or infant massage, right? It's like we also have to remember that many of these are complementary to the other therapeutic things we're doing. So that kind of goes into that asking why. So I get questions all the time of like, do you use oral motor tools? Or what about like vibration? Or what about this? Ask yourself why you're using it. If you are using that because the child's orally seeking and it is supporting their regulation, or it's helping to regulate their body so that they are ready to learn a new skill, they are in that position, then yes. But
Yeah.
if you're saying, oh, I'm using this because I'm going to build their oral motor strength, and you have a child who doesn't accept anything by mouth, they could be the strongest kid in the world. They're still not going to be able to chew the food. And I think that's where like the why question helps
Yeah.
you so much of like,
Yeah.
why am I doing this? And if I'm doing this because I want to build strength so that they can chew certain foods, okay, sure, I'll give that to you. But if you're doing that for weeks on end and they're not
Yes,
starting to chew
exactly.
food, you need to pivot. It's not because they don't have the strength for it. It's
Right.
something else. And that's when we also have to recognize like, or I'm using it for regulation. If they're still not regulated, what else do I need to do then? Because obviously that's not working.
Right. Yeah, I think that's the key too. If you feel stuck or if things are stuck, then yeah, like we can't get stuck there.
Yeah.
There were some other ones with
I
fear.
love the like over servicing, over diagnosing kind of examples.
So I think when it comes to confirmation bias too and the overdiagnosing, I think it's when that fear, you can look at a chart and see a bunch of diagnoses and you can have a picture in your head of what that child can do and what it's going to look like. And I've had babies or children get referred for a swallow study or for something like that because of a diagnosis. And I understand, but also like clinically, what are you seeing? What are you seeing functionally? What are you looking for? What are you trying to figure out? And are you limiting somebody because of their diagnosis? Because I could rattle off a list of diagnoses of one child who has made significant gains in 2-3 visits because they got the chance.
Yep.
The opportunity in a supported, loving environment,
Kind of goes into what I feel like this phrase is talked a lot about with AAC, but I find it very relevant to feeding is presuming competence. I think there's so many like rules around feeding that people look to because of, again, fear of, well, they have to be sitting up totally independently, or they have to be able to be in a 90-90-90 position, or they have, XYZ, fill in the blank, right? And a lot of times it's like, well, I don't like, I've worked with many children who have spastic quadriplegic CP. They're not going to sit in a 90-90-90 position. They can't. That doesn't mean that they're not capable of eating food. Or, a child who needs modified positioning. So they can't independently sit up on their own, but their head and neck is supported if you can support their trunk. So if you can support their trunk, they can participate in a mealtime. But if we presume they are not going to be able to eat, we presume that they're incompetent, then they're never giving that opportunity. And that's where like it goes to like what they look like on paper versus what are they actually presenting like clinically. And I think those are also examples, are like you get a child who maybe had a swallow study done when they were 6 weeks old, and now you're seeing this child at 4 years old. They haven't had a swallow study since. They haven't really eaten by mouth because they've gone through therapists that have fear-based practice. And you go, I guess I need a swallow study to start. And it's like, are you seeing something that tells you that? I mean, if they're not taking anything by mouth right now, what is the swallow study going to tell you?
And when we think about both questions, the fear-based thinking and the, just kind of being on autopilot, we would get referrals all the time where it's like, oh, they need their annual swallow study for school. Why? Did anything change? Why?
That doesn't make any sense. And I think too, sometimes like I've also seen that with schools where they're like, well, we won't feed unless we know the diet they can be on. Like we need the documentation of it. And some of that falls on to us also to support that education piece, whether you're, the providing therapist or the therapist at the school, to say, hey, school, why are we requiring this for all of these children? Why do we need the swallow study? Because
it's not changing what we're actually doing. You know, schools want to cover themselves, and that's a lot of
Right.
times where that stems from. But yeah, if nothing's changed, why are we doing it? Or thinking about too, like children, maybe you've like systematically weaned them off thickener. And I'll always get the question like, oh, well, do we need to repeat swallow study if they get down to thin to like make sure they're good with thin? It's like, well, are you seeing anything clinically that tells you they're not? And if
Yeah.
you're not, you don't need a swallow study. Like
No.
we don't need a swallow study to confirm they're doing well if they're doing well.
If you look at the research that came out of Boston on thickener weaning,
Yes.
what was it in like 2020 or
2018.
2018? Okay.
Yeah.
You're so good. You know the year. So yeah,
I love that article. Yeah, it was Walter and colleagues in 2018.
if you had glasses on, you'd push them up.
Yeah.
My glasses on, I'll push them up for you. Solidarity. Yeah. So they do talk in that article about how most of the children in that study, and I think there was, I don't know, close to 80, that on average they needed 1 to 2 studies to in the course of their treatment. And yeah, I think we're really quick to be like, oh, I gotta do it. I gotta check this box. And that why comes in.
Yeah. Yeah.
And also thinking about the whole picture and what that does to families. I've had parents where a swallow study goes well, and the mom is still hysterically crying after because it brings up so much past trauma, and it's so heavy.
Yeah.
And so really thinking about the implications of doing those studies and the radiation, all of that.
Yeah, there's so many other pieces to it, and the fear that goes into the caregiver going into it of like, they've been doing kind of well, and if we go to this, are they going to have to go back to some modified diet that they're, you know, also scared of? So yeah, it goes into like that, looking at that whole picture. I think the other thing I was going to say from fear-based thinking is sort of that overdiagnosis or over servicing as well, in terms of like someone comes to you and says, hey, I think like this is going on, and recognizing like a range of normal versus just assuming like, oh yes, it does look like they have oral motor weakness, or it does look like it's like, do they really? Like, do they actually have that? And like, if you are saying they have oral motor weakness or whatever it is, why? Like, how are you justifying that, and actually looking at like the child as a whole? Because I think there's also a piece of like just parents being concerned about XYZ, and not like, parents don't receive training or like education on like, here's a range of normal. And so they're going to constantly compare and constantly look at those things. And so also being able to provide some of like that guidance, and also recognizing like when our role as a feeding therapist is done versus like a child who maybe just still needs medical management of what's going on. But if you've gotten to them to that point of like, they can safely and effectively eat and enjoy it when they feel well, that's your role. Like that is it. And like, feeding therapy is not like, it should not be this lifelong or like years on end experience.
And I think we have to think critically about the words that we use with families as well, because words carry a lot of weight. And I see way too many babies where parents miss out on attachment. They miss out on those times and being present because they've been from provider to provider that is pathologizing everything and focusing on and calling everything an impairment, even when we think about that range of normal. And so parents get tunnel vision and they're so stressed. And just thinking about all those pieces to the puzzle, and like, for me, a red flag with any provider is like, because we know with pediatric feeding disorder, there are these different pillars and they intersect. And so if there's somebody who's only focused on one pillar, like only focused on oral motor, only focused on behavior, only focused on medical or nutrition, whatever it is, to me, that's a red flag. Because like, do they not understand the other pillars, or do they not, you know, it just,
it's very rare you're going to be, in isolation, but then also recognize like that just goes back to that whole picture of the child and trying to understand like what else is going on and what's influencing this. But also, I love how you mentioned like the attachment piece and the connection piece, because like
many children we work with are seeing PT, OT, speech. They also have to follow up with the GI and the cardiologist and the
Yeah.
pulmonologist and all of these appointments. And it's like they lose like being able to just be a kid and
Yeah.
like just play, because when other kids are playing after school, they're going to therapy. And so recognizing like some of those pieces as well, where like sometimes when we say, hey, like, you know what, we've gotten to the point where they're doing really well, they're thriving, like they can safely and effectively eat given like what, the strategies we've provided, and like go be a kid. Like go, it's okay for like a lot of those other things matter just as much.
More. Yeah.
I was gonna say, if not more.
Yeah, and same with thinking about, I think this is something when it comes to critical thinking that is so important, that has developed over time. Like I wanted in the beginning of my career to give all the things and know all the things and tell the parents all the things, and thinking critically about what can that person handle? What can that child handle? What is the priority here? Not giving these long, and even again, thinking about the words we use, like even calling things like exercises, or we're like, just making things normal, and like making it like, when you're eating a meal, just do this. Like when you're,
Yeah.
having it not everything be so pathologized and so like therapized. It just, I think that's super important for families. I've had families like one recently where the mom was like, I'm afraid to look at him if he's eating because I'm afraid like he'll stop. So I usually like turn away and I put the screen on, and like from the first visit to the next visit, they were like eating I wish I could have filmed it, but they were eating together and like enjoying this soup together. And it was so cool. It was so sweet.
Yeah. I think that really just goes back to how important it is to focus on like connection over anything else. Like that is most important. Everything else can follow if it will, right? Like a child will follow with all of those other things if they can, but if we focus on connection, like we won't go wrong. That is like, oh gosh, I could go on a tangent on that part and how important that is to meal times, because meal times are about more than just the nutrition that you're taking in. There's so many.
And it's more about, it's more than what your mouth is doing too.
Yes.
From infancy. Like I always, when I meet parents of like newborns or infants, and we'll talk about, I'm a speech therapist, so I think about communication. And isn't this beautiful that even if your baby's crying, they're communicating something to you, and you're able to try to interpret it and respond. And you're teaching them as little itty bitty babies already that they can trust you, and that you're going to try to understand them and respond and conversate with them, as opposed to like doing things to babies.
To them.
Yes. It just,
I know. I like this is a total side note, but like it makes me cringe sometimes not sometimes, all the time when I see this, but there'll be someone like posting a video on social media or whatever, and they're doing like some oral motor thing, and they're like, watch the baby like calm down after me doing it for a minute. And I'm like, they are dissociating. You can see the child like retract in, their eyes like look somewhere else. And I'm like, that child is not calming down, because if they were calming down, enjoying it, they're going to engage, and they're going to like hold your hand while you're doing it. Like, oh yes, that does feel good. Like they are dissociating.
Yeah. I always think about that if I see a family where they're like, in the beginning, like they come for their evaluation, they hated and now they seem fine with it. And I'm looking and I'm like, ooh,
yeah, they're tolerating, like, because they're just like, well, it's gonna happen whether I'm mad or not, so I guess I'll just comply. And it's like, that's a perfect example of compliance like based therapy over like connection based, right? So like, do they actually enjoy it? Because I feel the same way about oral stim and things like that. Do I like if someone rubs my temples and like I'm laying down and they're rubbing my temples and like, oh, this feels so good? Like, do I love a head massage? Yes, but it's only supporting like a short-term change. Like I'm calm for a minute, like during that period of time. And so also recognizing things as like complementary versus not, and only doing them if you actually have consent from the child that they want that. Like if the child is upset while you're doing it and they're pulling away and don't do it. Like,
Right.
especially like that goes into critical thinking as well as like that risk to benefit analysis of
Yeah.
the choices we're making. And, if the risk is that like this child is gonna become more orally aversive and the only thing they're accepting is like your fingers in their mouth, like what was the benefit you were trying to achieve with that? But if the benefit is that like they actually are calmer and more regular, and being supported, then like, okay, it might be worth what we're doing.
Yeah. I think about it even when I think about babies who are a little older or toddlers, and I always think about it like dating. And like you would hold hands right before you like kiss or like give and then give tongue
Yeah.
and like have so it's like, but a lot of times we're like jumping to the like penetration, like we're jumping to getting in the mouth, and it's like you gotta warm me up a little bit, like I don't know.
Yes.
And so it's probably inappropriate that I sometimes use that analogy with families, but I do because it's like if that baby or that child is not even comfortable on their hands touching a food and we're trying to shovel it in their face,
Shove it.
like shove it. Yeah, it's just like that is so much more vulnerable and invasive.
Yeah. That's why a lot of people don't enjoy the dentist. It's like, even though okay, they're just going to touch my teeth, it's going to be fine. Like it's invasive. Like
Yeah.
it is. But like, I don't know. People are just so quick to be like, but it's fine. No, like put your fingers in their mouth. It's super great. It's what they need. And it's like, no, they don't.
Yeah. Well, they're gonna tell us what they need.
Yep.
Yeah.
Now, if they're mouthing their fingers a lot, oh, looks like they want oral input.
Right.
Of the child who like never touches their mouth, you're like, so we need to desensitize the mouth. It's like, ugh.
Yeah, I get itchy. I get itchy.
Yeah.
It's even with, like the gag reflex, that's a good thing and it protects your airway and we're born with it and it matures naturally with input and experience. And we do not need to be desensitizing newborn gag reflexes. We need to
Two
be
fingers.
to
Like,
support. Yeah.
it's going to naturally evolve to the things it's supposed to.
Yeah. And we need to support, there are babies that need support that truly have a hypersensitive gag reflex for whatever reason. But again, we're figuring out why and then matching, whatever supports they need. But I think
and matching it to like a functional outcome, right? So like,
Yeah.
okay, we need them to be desensitized or like not even desensitized, but we need to give them exposures and opportunities to use a bottle nipple, right? So that they can be well fed, so that they can be like, we don't need them to.
And I think even the word desensitized, like
I know that's why I stopped because I was like, it's not even
like normalizing.
Like
We want them to have their senses. We don't want to desense that. Yeah.
Yeah. No, and that's why I like hesitated because I was like, it's not even the word I want to use. It's just offering opportunity. Again, facilitating, providing opportunities, but not like, I'm not going to sit there and like stroke their tongue to like get rid of this gag reflex.
Right. And I think too, it's hard and especially in the beginning and depending on the family, it can be really hard to coach and to collaborate care with families. But if we again think about efficiency and like how many visits, like I just see so many times it's like, oh, we're going to see them once a week for 12 weeks. So we're going to do, this intensive or whatever it is. But there are opportunities for the right family where you could meet once every 2 or 3 weeks.
Yeah.
And if you're giving them the tools that they really need, that child's going to make just as much, if not more progress. It reminds me of what you talked about in the beginning with like the intensive versus
bleeding.
Yeah. Where you might get to the same result, but for one, how much better and how much more confident did that family feel in their ability to parent and how much more time do they have to just be a family or work?
Yeah, exactly. There's like so many other clinical significance pieces we have to look at with that. No, I absolutely agree. Okay, so we're going to stop for this episode today. So what I think is, so for anyone who's listening, we are going to have a part 2 coming up that we're going to talk about then how to like build some of these critical thinking skills. So again, we kind of talked about my hot take of like, I don't think we can teach you how to critically think, but we can facilitate and encourage and provide some resources that can help you in building critical thinking skills. And then we'll talk about like incorporating critical thinking into a case. So check out part 2 to kind of go into like, okay, so like now how can I apply this and what does it look like in some cases? And so Tova and I will go through some cases like based on, real life examples of times that we've had to critically think through, but also like comparing some of the differences of like, okay, how would you look at this case? Like I'll present a case, Tova will blind react. Tova's going to present a case, I'll blind react, and we'll just like see how we think through it. So
I love it because it's going to be like choose your own adventure.
yes, yeah. It makes me think of those old Goosebump books. If you want to do this, turn to page, like you get to pick them on. So I'm really excited though, because I think it will hopefully be a good example of like, it's not cookbook. There's so many other pieces that come into it. And it's not necessarily that one singular approach is right or wrong. There's a variation that we have to consider. So I'm excited about it. But thank you, Tova, for our chat today. And I'm already so excited for part 2.
Yay, me too. Thank you.
Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow Bree, me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.